I'm Sarah Bonafide. I am a doctor of pharmacy over at Exeter Hospital. And I'm going to talk to you today about pharmacist home visits for the enhancement of medication reconciliation and reduction of hospital readmissions. So would you just go to the next slide? So I'm going to go over a patient case of a gentleman that I saw a few years ago. We'll describe transitional care and what that exactly means. Then we're going to talk a little bit about the program that we have here at Exeter. We're going to go over the meds, which is, I think, the one missing piece today. And then we'll sort of wrap things up and answer any questions that anyone may have. Next slide. Okay, so RJ was a 63-year-old gentleman, multiple admissions over the past 6 months. He was a type 2 diabetic, CHF, COPD, active smoker, actively on oxygen. He came to the hospital with the COPD exacerbation, very high risk for readmission. You know, this guy's sort of the typical in and out, in and out. Every time that he came in, every time that he came in, he would leave with multiple medications, multiple medication changes, inhalers. I think on this particular admission, he left with a prescription for Spiriva and Duoneb. Affordability of meds was always an ongoing issue. It really came down to, can he pay his rent versus can he pick up his medications? Social work was involved. When I went in the home, the application for Medicaid was sitting on the counter untouched. And of course, this gentleman had very low health literacy. So we will revisit that after talking a little bit more about what it is that I do. Next slide. So transitional care, what exactly does that mean? In recent years, this has really come to the forefront. And I think it's something that we're all familiar with the term. It refers to the movement of patients between healthcare practitioners, settings, and home. For example, a patient might receive care from a primary care physician or specialist in an outpatient setting, then transition to the hospital physician and nursing team during inpatient stay, and then move on to yet another care team at a skilled nursing facility. And then finally, the patient might even return home where they receive care from visiting nurses, friends, family. Some don't even let people in to help them. So it really is a very, very broad term that covers all the settings and all the people involved. Next slide. So transitions of care, they don't always go smoothly. Ineffective care transition processes lead to adverse events and higher hospital readmission rates and costs. Unsuccessful transitions of care lead to, 80% of serious medical errors are due to miscommunication during handoff. So that's obviously a pretty big number, and it's a pretty big area where we can really try to improve things. Hospitals need to reduce readmission rates and adverse events by improving the effectiveness of transitions of care in which they play a role. And as we're all very much aware, there's financial penalties involved if hospitals really can't do this. Beyond just not getting reimbursed for hospital stays, institutions now face financial penalties. And this really pertains to certain admission criteria, readmission criteria. It really goes on, and it's getting a lot of focus recently. Next slide. So what are the root causes of these unsuccessful transitions of care? Ineffective communication, which can include different expectations among providers, lack of teamwork, lack of respect, not enough time, lack of standardized procedures, Care providers don't always effectively or completely communicate important information among themselves to the patient or to the caregiver in a timely fashion. Patient education. Patients' family and friends sometimes receive conflicting recommendations, confusing med regimens, and unclear instructions about follow-up care. Patients and caregivers are sometimes excluded from planning related to the transition. Patients may lack sufficient understanding of a medical condition or the plan of care. And as a result, they don't have any buy-in to the importance of following the care plan or a lack of knowledge and skills to do so. And last, in many cases, accountability is really an issue. There's sometimes no physician or clinical entity that takes responsibility to assure that the patient's healthcare is coordinated across the various settings and among different providers. So really nobody is owning this piece of what happens when patients are going from one area to another. And as you can imagine, people will fall through the cracks. Things really, it can get a little muddy. It can create confusion for the patient and those responsible for transitioning the care of the patient to the next setting. Sometimes at discharge from the hospitals, PCPs aren't even identified by name. There is limited discharge planning and risk assessment. So it's obviously creating sort of a potential for a big issue here. Next slide. So transitional care at Exeter Health Resources. Who's involved? So Exeter Health Resources covers Exeter Hospital, core physicians, which is our group of PCPs and specialists, and Rockingham visiting nurses and hospice. The need was shown within the organization for the program that I helped develop specifically to tackle some of these issues. These were the three entities involved. So we all operate under one roof, but need a smoother transition between the three. So I'm a hospital employee, but I sort of serve as a go-between between the three, but we're gonna really kind of get into that in a minute. Next slide. So prior to 2016, when this program was developed, the VNA was experiencing an observed 96% discrepancy rate in medication lists when patients discharged from the hospital. So what does that really mean, and why is this such a big problem? Nurses in the field would be trying to admit the patient, they'd find the error, they would have to follow up with providers, they can't always get through, we end up with delays in care, lots of questions, patients aren't necessarily as satisfied with their level of care. It just goes on and on. Additionally, patients with CHF or COPD were coming back at a rate greater than 10%. So the goal of this new pharmacist-led program was to reduce the number of phone calls between providers as well as hospital readmissions, and sort of integrate within each of the EMRs and make it so it's a nice seamless program, nice seamless transition. Next slide. So here's my little roadmap of how things developed. Initially, we started the program with just a pilot group. So it was just a large group of minds trying to distinguish what exactly we wanted, how we wanted this program to look. That was early in 2016. Focus on CHF readmissions. And, eventually later on down the road, we did add COPD. It took most of the summer, so from June till about September of 2016, to really get all the proper permissions to allow me to access in all of the EMRs. So not just access for viewing, but access for reading and writing, making changes to the medical record. It was just miles and miles of legal, writing this, signing that. So finally in September, we got it off the ground. I saw my first patient within the first week. And, of course, we were all holding our breath every single day, waiting to see if this lady would come back, which she didn't. So that was pretty exciting. And then it was sort of full steam ahead. By January of the following year, so about 4 months later, we decided to add COPD. And that's really how it rolled out. Um, but obviously, COVID was a issue that none of us would have foreseen. But I will get to that in a little bit. All right, next slide. So what do I do every single day? So patients come into Exeter Hospital. Um, I screen them every day. So I go through the whole list of patients that are here, and I look for COPD, CHF, or both diagnosis in that patient's history. Um, are they here for a wound? Sure. Does it matter? No. As long as they have that diagnosis somewhere in there, they will fall within this program. During the hospital stay, they will come up with the discharge plan, the case managers, and that's when sort of they get flagged for me. Originally, we were looking at patients that only had a core provider. Um, Once COVID happened, we opened it up to non-core and core. But for this point in time, we'll just stick with the the core and qualifying diagnoses. So patient decides, okay, I'm going to go home. I'm going to accept Rockingham VNA services. At that point, they're enrolled in the Transition of Care Pharmacist program. While in the hospital, I make sure that I visit the patient at least one time. So first visit is just a introduction. I'm Sarah, doctor of pharmacy. This is what I do. I'll see you at home. I help you manage meds, answer any questions. A lot of the times they've seen so many people at that point that I'm not even sure everybody remembers me. At point of discharge, I go back. Now, if the patient discharges over the weekend, obviously I can't see them, but where I've made that initial touch point, they have my face in their mind somewhere. Ideally, I will discharge counsel. So what does that involve? Discharge counseling is going over med changes, new medications, meds that have been discontinued, really anything that falls within that. Here at Exeter, we have a great form that prints out, and I think most other hospitals have something similar. It's called the patient visit report, and it really just it spells it right out. This is your new medications, this is what you were taking before and how you were taking it, these are the medications that are changed, and so on and so forth. So I really use that document and going over things with patients. And it's great too, because the discharging nurse uses the same form. So there we have continuity. The patients are hopefully getting the same information. I do compare it to discharge summaries on the off chance that there was some sort of error in transcription, some sort of last minute change. Obviously, if you're sending people home with misinformation at point of discharge, it's a harder thing to catch. So I do occasionally find things like that, but not usually. And then one of the important things that we do is we use the Wasson Confidence Index, which is basically a ruler type question. How confident are you in managing your medications once you get home on a scale of 1 to 10? Now, most of the time, the people are, I think, gauging themselves quite high. I don't know if it's that they're ready to go home, they think I'm going to stop up the discharge or what. But usually it's around 7 or greater that these folks really do think that they've got this, they've managed their meds for years, and they won't have any questions in the home. Next slide. Okay, so I've seen my person and they are discharging. So then I go back to the office. I take what we call is the best possible medication list. So when they come into the hospital, we have just a fabulous, fabulous med rec team that sees them in the emergency department. And they go to really all ends of the planet to find out what these people are taking. So we take that list that the MedRec team develops at point of admission, we carry it through the whole hospitalization, and then at point of discharge, any appropriate changes that are made, either by the physician or the specialist, are then carried into the outpatient world. So what does that mean? Medication reconciliation, obviously another one of those, hot topics of years recent. So I do the med rec outgoing. I take that list that we consider to be their gold standard list, and I put it into the system that the core physicians use. And I go through, I make sure everything is correct, update it, and I will send the PCP a note, just a quick, this is what I changed. This is what we talked about. If there were any sort of interesting points that the patient may have brought up at point of discharge, anything that I might think is pertinent to their care, that the physician who's following up after the fact might need, I try to include that. Obviously, I don't want to put a novel in my note because it'll just get lost in all the text. And then what I do is I actually take the same list and I will upload that into Rockingham VNA's system with the same note that I sent to the PCP and the same note that I put in our system here at the hospital. So as you can see, it sort of closes the loop with everything. We all have the same med list. We all have the same information. And that is, I think, a good starting point for when the patient goes home to know, that all of the care providers involved have the same list. I try to see patients within the first 24 hours after discharge. Now, obviously, that's not always ideal, but I do try to get out there for the home visit as soon as I can. I think at the hospital, we had a study where we were able to show that most people returned within the first 3 days if they were going to return. When COVID-19 happened, obviously all the home visit stuff sort of came to a screeching halt, and we really didn't know what to do. So we transitioned it to a telephone visit. Obviously, that was a lot easier to make and touch a lot more people. But the home visit is really the bread and butter of this program. When you're in the home, it's such a different world. And I think people come into the hospital and they, for the most part, are on their best behavior. They don't want to be here. They want to go home. They're not feeling very well. But when they're in their home, it's sort of their realm. And I think people are a lot more honest and forthcoming with questions and concerns and fears and information. What's really been great is working with the visiting nurses so that we have that follow through even after I've been to see the patient. It's a great way to sort of keep a finger on the pulse of what's going on. So the in-home visit, we do a full session of medication therapy management, motivational interviewing, and then at the end of the session, I use the same Watson confidence index tool to ask that patient, okay, now I've seen you, now you're home, how confident do you feel in managing your medications? And we were able to see an improvement in that, but I'll get to that at the end. Next slide. So after the visit, as I said, at point of discharge, I really try to be rigorous in sharing all the same information with the same people. So where does that information that I see in the home, where does it go? It'll go back to the primary care physician. So I do a post-visit follow-up note. If there's any questions, if there's any concerns, I had one gentleman who left and he had, I think it was 2 different antihypertensives and could barely walk. He was just so dizzy. Blood pressure was just, bottoming out every time he stood up. And we were able to same day, talk to the physician and get that changed. I think they ended up stopping one of his new medications. Um, and that takes some of the workload off of the home care nurse so they can focus on other things while they're there. Um, I will always update the med list in the EMR, while I'm in there. So, I make sure that they have the medications in the home. I make sure that they're taking them correctly. Um, we talk about, things like, do you think it's important to take your medicines? Lots of open-ended questions with these people. And that leads to really good dialogue. And, it's just a great way to keep an eye on things. And then I send that information off to the physician. One thing that I always do is at the end of the visit, I always offer them my business card, and I tell people it really doesn't matter, if it's the silliest sounding question in the world. Um, oh, if this is just a silly question or whatever, you know, please always feel free to call me and ask. So I always try to leave my door open to people, and I hope that that really kind of makes a difference with them, because I'm not seeing 10 patients in a day. I'm seeing 2, maybe 3, and that leaves me a lot more space to go back and revisit things and really hopefully help these people. Um, Next slide. So to kind of go back to what it is that I do while I'm in there, um, medication therapy management is a part of it. Um, so what is medication therapy management? It is a service that's provided typically by pharmacists. It aims to improve outcomes by helping people better understand medications. Um, are the meds that they are taking appropriate? Are the medications that they are taking necessary? Are they working? Um, is there someone that's actually looking at all of these things? So what we tend to do is we have all these specialists and all these people owning one piece, but everybody's on meds. Um, Everybody's, taking a lot of meds. Adults 65 and older um, are taking, I have it 40% of aging adults are taking between 5 to 9 medications every single day. 18% are taking 10 or more. I mean, that's a pretty big number. And that's a big pill burden, that we don't really think about. And then you end up with prescribing cascades, and it's just sort of a slippery slope if nobody's really watching over it. Um, so Beer's criteria was developed, and it really helps to standardize meds that behave differently in an aging population. So it's widely used by healthcare providers, researchers, educators. Um, Basically, the point of Beer's criteria is just identifying meds that are potentially inappropriate. So it flags certain medications that may behave differently in an elderly, puts them at risk for falls. Um, it's just a good list of medications that you might want to look out for and be monitoring for when you are in the home and talking to these folks. Next slide. So to the 4 M's. So my M would be medications. If a medication is necessary, use age-friendly medication that does not interfere with what matters to the older adult, mobility or mentation across settings of care. So do any of the patient's medications affect the other M's? And that's what we're really looking out for. And I think that's really one of the biggest takeaways from this conference today is that all of these things work together. So if we can make one piece work, it's only going to help the other three M's with these folks. So every time you're in there in the home, I'm making sure I'm reviewing for those high risk meds, those meds that are on the Beers list. We can deprescribe, we can dose adjust whenever it's possible. So what are those meds that I'm looking out for? Next slide. So the big classes of medications, and I'm not going to do tables and tables of meds, I promise you. I just wanted to touch a few of the important classes because I know that would end up becoming, just a massive snore fest in here. So the benzodiazepines, I mean, I think everybody's aware of that. Older adults have increased sensitivity and increased risk of cognitive impairment when taking these. Increased delirium, falls, potential for fractures, motor vehicle crashes. So it's really a med that you want to avoid in the elderly. Opioids, it's really the same as the benzos, increased sensitivity, respiratory depression, things like that. So any meds like that are going to be focused on when you're seeing them in the aging adult population. Highly anticholinergic medications. So first generation antihistamines like Benadryl, it's a big one. People don't think about it. Your average patient may not realize that Benadryl 20 years ago is going to behave a different way in their body now. And they think over the counter, that's relatively safe. And it's not always the case. It can really, really behave kind of funny, put them at risk for things. So these medications, they don't get cleared as rapidly with age. Tolerance can develop when they're used with a hypnotic. It increases the risk of confusion, dry mouth, constipation, and it can even end up being toxic in the elderly population. So again, another one that per Beers criteria, you definitely want to avoid or really weigh out risk versus benefit when you see people using them. Next slide. So of course, any prescription or over-the-counter sedatives or sleep medications. So Ambien or any of the other Z medications, adverse events are similar to those with benzodiazepines in older adults. It's increased emergency room visits, hospitalizations, motor vehicle crashes, with really minimal improvement to the patient's sleep latency and duration. So it really doesn't do its job for the amount of risk involved in aging adults. Melatonin, I included that one there because I see it more and more with my patients. I think it's another one like Benadryl that folks think, especially the melatonin, they think that it's natural and therefore it's benign. But one thing that not a lot of people realize is that as you get closer and closer to a 10 milligram dose of melatonin, it actually has a paradoxic effect, which I'm sure all of you know. It means that it'll actually wake you up. And we've actually seen this in hospice patients that they're just taking tons of the stuff and it actually has the opposite effect and it's keeping them awake. So definitely something that you want to keep an eye on, something that, isn't necessarily the greatest option in my opinion. I always look for muscle relaxants. Flexeril is probably the most common one. They're poorly tolerated by older adults, and some have anticholinergic adverse effects, increased sedation, and an increased risk of all those or increased risk of fractures in older adults as well. And of course, last but not least are the tricyclic antidepressants and antipsychotics. So these are highly anticholinergic, sedating. They can cause orthostatic hypotension. It's definitely something that you want to avoid. except maybe in cases of schizophrenia, bipolar for short term as an antiemetic during chemo. Um, just really another one that I think people don't always pay attention to, and it really should be watched out for in this population. The next slide, please. Okay, so back to the fun stuff. Um, so the program. So what exactly happened? So we've been tracking data, and the first year after rollout, we saw 176 patients in the home, or rather, I discharged 176 patients. Sorry, 96 of those patients allowed me into the home, and the outgoing spiel that I give these folks has definitely evolved over time. Initially I used to see them in the hospital and ask permission. Um, can I come see you? Can I follow up with you? I got a lot of, oh, I have a pharmacist. It's Joe down at CVS. And I'm sure Joe at CVS is a fabulous practitioner. But he's not there in your house. So, that's kind of evolved over time to now I just say, I'm coming and you better be ready for me. So, initially the program, it got better and better. So of those 96 people, 4 came back. And that gave us about a 4.17% readmission rate, which, obviously just a stellar number that I think really none of us thought it would be so successful, right out of the gate. And just for a source of comparison, Exeter Hospital readmission rates for at that time for CHF hovered at around 18%, and for COPD were almost 17%. So obviously you can see that that's a pretty big change and a pretty great improvement. The Wasson Confidence Index, we saw an improvement in people's gauging of their confidence from an average of 7.56 at discharge to about 8.87 after home visit. Now that being said, I think when people self-gauge their confidence, there's always a lot of other factors. So I would certainly take that number with a grain of salt, but we did see an improvement, I think, and that's the important thing to take away. Emergency room visits and observation admissions were not included in this number of readmissions. So I will say that. And then the other point of interest that we were looking at was the telephone call rate from visiting clinician in the field to provider actually decreased from 96% of all patients down to 0. So any of the patients that I did med reconciliation for really didn't need the call, because the med rec on the outgoing side was, it was done correctly. So that was obviously another really, really great improvement and a big number that we saw in that first year. Next slide. So I know I've kind of alluded to the COVID-19 and current state of this program and what sort of has gone on over the last year. But I sort of wanted to leave it to its own slide altogether. So, obviously none of us saw COVID-19 coming. When we shut down in March, we really didn't know what the future of this program would look like. And so we really had to kind of go outside of the box here and figure out, how are we still going to touch these people and make a difference? So what we did is we transitioned the home visit at that point in time to a telephone visit, which again, it took me some time to get my routine down with these folks and be able to make the biggest impact over the phone and no longer in person. One thing that the telephone visits did do was that it allowed us to open up the program to non-core patients as well. So what did that mean? It was just CHF, COPD, and going home with Rockingham VNA services. So obviously no med rec to the non-core providers, as I don't have access to every EMR. But still, it's an added touch point for these folks that otherwise may have fallen through the cracks because they didn't qualify for this program. It's allowed me to, quote, see more patients, but it's not necessarily as in depth or as juicy of a visit. So in 2021, as things have started to evolve and calm down, and I'm fully vaccinated, and restrictions are starting to lift a little bit here and there. We've been able to reintroduce home visits, obviously being as cautious as possible, and then keep the telephone visits. So really what we're doing now is we're doing all of those added patients, and we're doing some via the phone, and then we're doing the high risk ones, the ones that have come back, the ones that I know because I've seen them year after year, the ones with lengthy med lists, lots of changes, anyone that seems really, really high risk. We're making sure that I'm getting in the home with those folks and really seeing them to see if we can have an impact with them. Next slide. So back to our patient, RJ. So what happened with him? So he came home. I saw him before discharge, and then I followed up with him in the home. We were able to organize his medications, which, were all over the place, pill bottles next to the sink, pill bottles in the bathroom, a couple by the bed. We put them all in one place. We were able to organize things into, I don't think he was really ready for a pill organizing box per se, but we put things that in a much more ordered fashion. I was able to identify the most important therapies. So I don't know if you remember, but I said before that affordability of his meds was really, really a big issue for this guy. And it really kind of came down to, can I pay my rent or can I get my medication? So that's obviously tough. And what we were able to do is we were able to identify, what's going to have the biggest impact for him for medication and is still going to fall under the affordability thing. So we were able to kind of pick out what he can get. And what we ended up doing was going more with nebs. I think he was sent home on an inhaler, and it just, really wasn't within the realm of possibility. We got social work back in there with him. I was able to go over, the proper use of his nebulizer machine. And then I even did a smoking cessation session with him. So that was excellent. And that, that's really one of my favorite things to do, is to talk to people about quitting smoking and giving them some pearls and techniques for doing so. I even was able to arrange a nutritional consult at Rockingham VNA. We have a fabulous nutritionist on the team, and she was able to come in and really help him in identifying, what are the healthy things, what are the better options. And all in all, this gentleman was able to stay out of the hospital for almost 6 months, which was a vast improvement for a gentleman who was really coming in, every couple of weeks or so with, the same issues ongoing. So that was sort of I guess a happy ending for this fella. Next slide. So we have found that pharmacist intervention is beneficial for the patient. There's more time at home, not in the hospital, which is ideal for most, a higher quality of life. We've been able to sort of provide people with, I guess, a jumping point for managing their own medications themselves. For the healthcare facility, we've obviously eliminated call volume to nothing. And not having staff doing the same things over and over and over again, so they can focus on that patient and focus on care. Next slide is just my references, and the next slide is I think I saw a few questions. Sorry if I went over.
No, Sarah, you perfect timing. So I sent you 4 questions, pulled them out of chat
Okay.
and sent them directly to you. So, and I can
Okay.
just ask them to you so you can respond. So the questions were about who's involved when you are making the home visit. Do you provide pillboxes, and do you find that there's a difference overall in medication adherence for patients who typically have not been real adherent to their medications? You want to go with those 3, and then
Sure.
there's a
Sure.
specific question about billing and coding.
Oh, okay. So ideally, I do try to piggyback on with the nurse, the admitting nurse in the field. So what do I mean by that is the initial nurse who's going out to admit the patient or readmit the patient to Rockingham VNA services. I try to kind of time it so I'm there either with them or, right before them or right after, so that we're not barraging these patients with 9 million people in their home the day after getting out of the hospital, which obviously can be a bit overwhelming for people. Um, the VNA actually does provide the pill boxes, which are great. And I think they have 4 different pockets per day. And then it has the VNA's phone number and information right on the side of it. And then what was the third question? I'm sorry.
For patients who typically have been non-adherent with their
Oh,
medication regimen, do you feel like your visits and the work you're doing has improved that?
I do. I do. That's sort of where the motivational interviewing comes in. So basically what motivational interviewing is just lots of open-ended questions. And I know it sounds kind of silly when you first start doing it, why do you take your meds? Why do you think they're important? What's important to you? And then the more you do it, it becomes more and more natural. I actually find myself talking to my kids this way and then, cursing the program. But, it really initiates people to doing it themselves, and it gets them to thinking, so I'm not really there to boss you around. I'm there to initiate change in a way that, these folks are really kind of thinking that they're doing it themselves. So I think we have seen better adherence and better results in that way.
Great. Thanks for referencing the motivational interviewing. It's so important for everybody. So the last question we'll leave you with is from Dr. Janice about documentation that you provide back to the provider, and does it meet the billing requirement for CPT 2111F, which is
Okay.
medication reconciliation post-discharge, or are you
Yeah.
billing?
So we actually are not billing. So this program was actually originally funded through a grant to the VNA. And then we saw such success that we actually were able to budget for the position. So the patients are not actually billed.